Hello, this is Anudeep, a second year medical student. Can you please confirm your name and age?
This is Mandip, age 22.
Okay. Today, I would like to perform musculoskeletal examination, which includes assessing your shoulder, hands, and knees. Will that be okay?
Okay.
Before beginning, do you have any kind of pain?
No.
Okay. Can you please take off your shirt so that it will be easy for me to
Okay.
examine? Okay. Begin by inspecting the shoulder and shoulder girdle anteriorly and inspect scapula and other related muscles posteriorly. During the both inspections, note for any kind of swelling, deformity, muscle atrophy, or any kind of tremors of the muscle. And now, palpate for the tenderness at sternoclavicular joint by tracing the clavicle laterally with the help of your fingers. And now, from behind, follow the bony spine of the scapula laterally and upward until it becomes acromion, the summit of the shoulder. From these, palpate the acromioclavicular joint and from there down to the coracoid process of the scapula. Palpate the greater tubercle and also the biceps tendon in the intertubular groove, checking for the tenderness. And now lift the humerus posteriorly so you can palpate over the subacromial bursa and the subdeltoid bursa and the also underlying palpable sits muscles, which include supraspinatus, infraspinatus, teres major, and subscapularis. And now ask the patient to perform 6 motions of the shoulder girdle. Firstly, flexion, followed by the extension, and then ask him for the abduction, and then ask him to perform adduction, and then internal rotation, placing a hand behind his back to touch his shoulder blade, and then ask him to do external rotation, rotating arm towards the ceiling from the shoulder level. Now, in this test, elevate the patient's arm to 90 degrees of flexion and then get the arm at the maximum horizontal adduction. A positive test produces pain on top of the shoulder near the acromioclavicular joint. Now, for Rapley scratch test, ask the patient to try and bring the hands together on the back while one hand comes from the above and one from the below. The patient should repeat the movement with switched arms while you are going to check for the differences. It is often seen that dominant side shows more restriction than the non-dominant side. And now for this test, stand behind the patient and use one hand to stabilize the scapula and then bring the arm into maximal passive shoulder flexion. This test is considered positive if the patient experiences any kind of pain during the maximal shoulder flexion. For Hawkins impingement sign, have the patient in sitting position with the affected arm in 90 degrees of the shoulder flexion and the elbow flexed to 90 degrees and then fixate the scapula with one hand and hold on to the patient's elbow with the other hand and add the passive internal rotation to the glenohumeral joint. This test is considered positive in case of any patient's familiar shoulder. For the drop arm test, move to the back of the patient to perform this test Have the patient in sitting or standing position. Bring the affected arm into 90 degrees of abduction and external rotation passively. And then tell your patient to hold his position and release slowly your supporting hand. This test is positive if your patient unable to slowly control the downward movement. Empty can test. For this test, have your patient be in sitting or standing position. The arms of the patient are elevated to 90 degrees in scapular plane. The arms are then fully internally rotated so that the thumbs point towards the floor. And now, the patient is then instructed to resist the downward pressure applied by examiner. The test is positive if there is any pain of the affected arm. Examination of wrist and hands. Observe the position of hands in the motion to see if the movements are smooth and natural. When fingers are relaxed, they should be slightly flexed, and also inspect for the patient's wrist and hands, noticing any swelling over the joints as well as any deformities. Observe the contours of the palm, namely thenar and hypothenar. Note for any kind of swelling on thenar and hypothenar areas of your palm. And now, palpate the distal radius and the ulna of the lateral and the medial surfaces of the wrist. Now, palpate the radial styloid bone and also the anatomical snuff box. Pain when palpating snuff box suggests scaphoid fracture. And now palpate the 8 carpal bones lying distal to wrist joints and then each metacarpopharyngeal joint. And now palpate the medial and lateral aspects of each of the proximal interphalangeal joints between the thumb and index finger. Look for any kind of swelling, burginess, bony enlargement, or tenderness. Repeat on the other hand as well. For the range of motion of wrist and hands, begin with flexion and extension. Ask your patient to turn his hands palms up and then just bring the fingers up towards his face and then down towards the toes. And continue to assess by adduction and abduction. Ask him to bring down the wrist in the flat position and then turn it away and towards you. So that's adduction and abduction of wrist and hands. Hand grip strength. For this test, ask your patient to hold your fingers firmly. After holding those firmly, ask him to squeeze as hard as he can. Loss of the strength may indicate arthritis and even cervical radiculopathy. For the Finkelstein test, ask the patient to grab his thumb in his palm and ask him to squeeze as hard as he can. Make note of any kind of wrist pain towards the midline. A positive Finkelstein test for Dequervain's tenosynovitis. Thumb abduction test is done for the carpal tunnel syndrome. Firstly, lift the patient's thumb slightly away from him. Simultaneously, observe the patient's face for any kind of pain. For the tinel test, gently tap on the median nerve of the patient and ask him for any kind of pain in his second, third, and fourth fingers or any kind of tingling in those fingers. For the Fallon test, ask your patient to put the back of his two hands together and ask the patient whether he has any kind of problem in his second, third, and also the fourth fingers, or even if he faces any kind of tingling. Examination of knees. Keep the patient in the supine position and his knees in the flexion. Inspect the knees, noting their alignment and any kind of deformities. And also, note normal halos around the patella or atrophy of quadricep muscles. And now, straighten the patient's legs and palpate the suprapatellar pouch on each side of the quadriceps and note for any kind of swelling. And now palpate the tibial femoral joint, the edge of the tibial plateau and the margins of the joint and note for any kind of irregular bony ridges. And now palpate the medial meniscus and then the lateral meniscus. Tenderness suggests the partial tear in this. Now time for checking Burl sign. Having the patient supine with knee extended and muscles relaxed, now sweep the medial recess of knee joint upward such that any fluid is displaced from median side. And now sweep from the suprapatellar pouch laterally and downward over the lateral recess of knee joint to push fluid back into the medial side and look for any kind of Burl sign present. For the Ballardman test, have your patient lying in supine position with fully extended leg and then stroke downwards until you reach suprapatellar pouch and press downwards with the other hand. Perform the same movement and stop just below the apex of the patella. While applying downward pressure, take one finger and press on the patella and see whether it is floating. If you see patella is floating, then the fluid is accumulated under it. McMurray test. Having your patient lying in supine position with tested knee fully flexed. Now, rotate the tibia medially and bring the knee to the extension. We need to repeat this process a couple of times with different angle of knee flexion. And now, in order to test medial meniscus, bring the knee to full flexion and laterally rotate the tibia. This test is positive if the patient experiences clicking, locking, or any kind of pain in his knees. In this test, firstly secure the ankle with one hand and place the other hand around the knee so that the thin area against the fibular head. Now push medially against the knee and laterally against the ankle in an attempt to open up the knee joint on inside. And now look at the variation in 30 degrees of the flexion. Slightly move the lower leg to the side of the bench as it helps in preventing hip rotation. Now repeat the same by pushing medially against the knee and laterally against the ankle. At 30-degree flexion, the knee adopts maximally loose position and MCL in primary stabilizer. And whereas at 0-degree flexion, hamstring and posterior medial capsule are tensed. And now it's time for the varus stress test. Place your patient in supine position with the legs fully extended. Instruct your patient to relax as much as possible. Grab on the lower leg with one hand just above the ankle and fixate with the other hand on medial side of femur. Apply the lateral rotation in the knee joint and perform passive adduction. Consequently, perform the same test but now with the knee in 20 to 30 degree of flexion. Repeat the same process. Grab the lower leg with one hand just above the ankle. And now fixate with the other hand on the medial side of the femur. Apply the lateral rotation in knee joint and perform passive adduction. So that completes this test. Anterior drawer test. To perform this test, bring your patient's hip to 45 degrees and your patient's knee to the 90 degrees of flexion and sit on his toes. And now palpate the joint line with the thumb and try to move tibia anteriorly in explosive movement. This test is positive if tibia moves anteriorly more than 6 millimeters. Lachman test. To perform this test, have your patient in supine line position and bring your patient's leg into 30-degree flexion. Fixate the femur with your other hand. And now, bring the tibia into slight external rotation and try to translate tibia anteriorly. This test is positive if you experience any kind of soft or mushy feel. Posterior drawer test. Have your patient lying in supine position. Be seated on his toes and ask your patient to flex his hip to 45 and knee to 90 degrees. Palpate the joint line and push the tibia posteriorly. This test is positive if tibia translates posteriorly more than 6 millimeters. So that completes the entire procedure and everything is fine. Thank you. Thank you.